While Ebola virus disease is primarily recognized for its profound hemorrhagic complications and systemic shock, direct and indirect cardiovascular involvement is a significant and often fatal component of the clinical picture. Ebola virus can induce significant myocardial inflammation. Post-mortem immunohistochemistry of fatal Ebola virus disease cases have demonstrated abundant viral antigen in the endothelium, the endocardium, and the extracellular spaces of the subendocardium. Recent cardiac MRI studies of Ebola virus disease survivors have documented findings consistent with the Lake-Louis criteria for myocarditis. These include elevated native T1 and abnormal extracellular volume fraction, indicating acute myocardial edema and capillary leak. Diffuse left ventricular hypokinesis resulting in reduced ejection fraction. Late gadolinium enhancement on follow-up imaging signifying progression from acute focal inflammation to myocardial fibrosis. The inflammatory state and direct myocardial injury frequently disrupts the heart's electrical system. QTC prolongation. This is a notable and frequent finding during the acute illness. Significant QTC prolongation acts as a strong predictor of poor clinical outcomes and predisposes the patient to life-threatening ventricular arrhythmias. Heart rate dysregulation. Patients may present with relative bradycardia early in the clinical course, which often sharply transitions to profound sinus tachycardia as intravascular volume depletion and systemic inflammation worsen. The hallmark terminal event in severe Ebola virus disease is a complex multifactorial shock. It is rarely purely hypovolemic, even with the profuse gastrointestinal fluid losses characteristic of the disease. The virus directly infects mononuclear phagocytes and endothelial cells, triggering a massive cytokine storm, upregulation of pro-inflammatory cytokines, and disseminated intravascular coagulation. This leads to profound endothelial dysfunction and third spacing. Third spacing is the abnormal shifting of bodily fluid from the bloodstream, that is the intravascular space, into non-functional body spaces such as the space between cells, that is the interstitial space, or body cavities. When you compound this severe distributive and hypovolemic state